Carolina. I'm also a past steering committee member at the National Colorectal Cancer Roundtable. And I want to take a minute to thank you for joining. We have had lots of interest in this topic, and we appreciate you taking the time to come and listen in today, as our speakers are amazing. I am going to ask for Caitlin to move the slide. Thank you. So today, we're excited to share with you the presentations from 3 leaders who do community-facing health systems that are utilizing various tools to establish and implement and advance colorectal cancer screening interventions that are tailored for the population they serve. You will learn about unique barriers patients face in their communities and the strategies that they took to assist patients in overcoming these barriers. Slide. So during the program, you will hear from Dr. Batarseh, who's the Chief Resident Internal Medicine, Preventive Medicine at the University of Buffalo, the State University of New York. You will also hear from Ms. Tiffany Taylor, who's the Ambulatory Administrative Director in the Department of Family Medicine at Charleston Area Medical Center. And finally, you'll hear from Dr. Desai, who's the Assistant Clinical Professor of Medicine and Curriculum Director at the Southwest Campus of the Medical College of Georgia in Augusta, at Augusta University. So as we get started, we'll look at a few housekeeping. The event is being recorded today, and the replay and speaker slides will be shared with you. Please feel free to share with your colleagues if you're not able to join us today. Also, because there are a large number of participants, we ask, and we have taken the opportunity to mute you today, and we encourage you to ask any questions in the Q&A box. We will have time for a few questions at the end of the meeting. And if you have additional questions, feel free to email us, and we'll make sure that answers are emailed to you. Finally, we're always trying to improve our webinars, so we are asking you to take the minute to answer our evaluation at the end. It's really important to us, as we always seek to do best, and your feedback is appreciated. And so with that, I am pleased to turn it over to Dr. Batarseh, who will share her work with you and how she's addressing colorectal cancer screening disparities in Buffalo, New York area.
Hello, everyone, and good afternoon. I'm excited to share our project today. Again, my name is Einas Batarseh, and I'm a 4th year in a combined program, internal medicine, preventive medicine at Buffalo. Today, our project is the project that's conducted in a North Buffalo clinic to improve colorectal cancer screening rate. We did have the focus on addressing disparities to improve the rate in patients from underserved communities. Next, please. No conflicts to disclose. This project was supported by an American Cancer Society grant funding. The views are of my own and of my own team as well. Next, please. As of our agenda, I will discuss our specific purpose and the inequity problem that we had. I will want to share tools that we used and can be replicated at any other healthcare facility. It's mainly to improve the rate and discussing quality improvement tools that can be utilized to understand your population, the needs in your health facility, successes and failures, and our future directions as well. Next, please. Right from the get-go, our main aim for the project was to increase the rate from less than 30% to 40% within a 12-month period. That being said, we definitely have the continuous improvement goal of reaching the 80% that we're all hoping to achieve as well. I think, and I believe it doesn't come as a surprise that the screening rate for colorectal cancer has been for a long time a source of concern, and our clinic in North Buffalo was no exception. We did have a lot of difficulties, and especially they were also increased during the pandemic. Moreover, despite knowing that African Americans have had the highest mortality rate, they remain the lowest among the screening rate. And our first measure was the screening for overall as an outcome, but we also wanted to measure our progress. So we have our process measures for the stool test and the colonoscopy order rate and completion rate. We also focus to have an improvement in the knowledge for the providers and the staff, and making sure that we're not interrupting the workflow in the clinic. So we have our patient satisfaction rate and the provider and staff satisfaction. Next, please. This is one of the main and a very important quality improvement tool that we utilize to understand the barriers that we had in our patient population. So we wanted to have the focus of the social determinants of health, addressing if the patients have a transportation barriers, language barriers, and also health literacy. More about patient-related factors in fear of diagnosis, inability to understand how to do a stool test, and having any difficulty in returning them. Regarding the colonoscopies, we did have patients having the fear of prep and having issues with scheduling. Therefore, we wanted to make sure that GI clinics are involved. Without going more on that, we wanted to have a system approach. So we identified navigational complexities within the EMR itself. And it goes without saying, making sure that the providers are updated on the most recent guidelines and how to do the process within the clinic as well. Next, please. This is a stakeholder mapping analysis. And if you can look at this diagram, it represents evaluating the level of influence and the level of interest of different stakeholders. I always say that the most thing that we're proud of is using the multidisciplinary approach and having different providers from different departments and also different staff members to help us within the project. It's important to emphasize that when you go, this is for quadrants, and when you go high to the top, you will have higher level of influence. Going to the right, it's a higher level of interest. But to make sure that when you're evaluating, to be realistic, and the level of interest and is including also how much those departments are able to prioritize your project and how much they have time to be involved as well. Next, please. This is a busy slide, so let me flip it for you to be into something that's easy to understand. The driver diagram comes from initially having the primary drivers. Those are conducted from the root cause analysis that we did earlier. And then the secondary drivers would be able to ignite the primary drivers. It's almost coming from the right to the left as a domino effect. So in order to have an evidence-based practice, you need to educate the providers and the staff as well, and have them know what tools that we have and what options for screening. We address the social determinants of health, also by making sure that cultural competency education is there, streamlining the workflow and having an EHR template to be conducted. And one of the cornerstones of our project is having the patient involved in the decision making. So with that, we wanted to make sure that we're addressing health literacy, having special messages to increase their interest, and also having a patient navigator to improve the outreach. Next, please. This is a process flow map, which we developed to make a guidance for the providers and residents in the clinic to know a step of what they should do. So from the patient arrival to the clinic, verifying within the EMR if the patient is due, and then having a risk stratification to know if the patient is average risk, high risk, and what they would be eligible for, a colonoscopy or colonoscopy and a stool test as well. And it's important also within this flow map is if a patient returned a stool test that is positive, to know that every positive stool test deserves a full colonoscopy to say that the screening is done. So without having the complete process, the screening is not done. And those steps are highlighted in one by one to help the residents kind of as a memory guide, knowing what should be next conducted. Next, please. A strategy is the PDSA cycles. It's more of a timeline, how we conducted the processes across the years, starting with the education, having some templates to make documentation faster, and a baseline patient registry. We also did some videos, which I will show you some samples to educate patients about the colonoscopy and stool test and importance of screening, having patient navigator, and leveraging the database and being able to have a special approach to outreach and helping the patients in scheduling as well. Next. I'm going to share with you some simple tools that we used as educational tools to the patients. If we start with the first one, this is a very simple paper that we gave to the patients to understand what to do with the stool test. And we made it in simple language, addressing the literacy. And what we tell the patients, this is 5 steps, do it in 5 days, call the number that's after the step 5. And this was done in Arabic, English, and Spanish, and helped tremendously in making it less overwhelming to the patients who ended up being eligible for a stool test and decided to go with that option. Next, please. This is a pocket card that we made as a memory guideline. It looks busy here, but it's kind of double-sided. So it has the step-by-step of what to do if one of the residents received a positive stool test before and the patient is not in the clinic, what to do, and more guidance about the risk stratification. So they would have it with them, and there is a QR code if they didn't have it, so to reach out to it easily. This is an educational video sample. So we were happy that a lot of the residents and staff volunteered to do an educational sample. And we had a longer ones in Arabic and English and Spanish. I just included a quick one for you to see what we're doing, and we will be sharing with the patients.
American Cancer Society has announced a partnership with Elmwood Hurdle Internal Medicine, a Kaleida Health facility, to improve colorectal cancer screening rates as part of the national ACS Get Screened initiative. The focus of this initiative is to partner with institutions across the country to drive quality improvement processes and interventions to deliver cancer screenings appropriately, safely, and equitably.
Colon cancer is the second leading cause of cancer deaths in the U.S. in men and women combined, yet it can be prevented or detected at an early stage.
Good afternoon, how are you?
Good afternoon, doctor. How are you?
Good to see you. You know, we haven't seen you for a long time due to pandemic.
Yes. I'm glad to get in here.
Yeah, good. So I wanted to talk to you about colorectal cancer screening.
Okay.
Because of the pandemic, I know we put it on hold. Mm-hmm. But it is a good time to discuss now.
Okay, yes.
Is that okay?
Yes.
Feel healthy? This is a great time to get screened for colon cancer. It often starts without symptoms. Call your doctor, get screened.
American Cancer.
All right, coming to the results right now. And as I mentioned, we did provider education about the guidelines and social determinants of health. You can see that the residents did have a good baseline. There was a nice improvement in understanding social determinants of health definitions and how to address them, going to a 96% from 74% as their scoring in the exams pre and post test. Next, please. Now I'm going to show you run charts of the overall CRC screening rate. If we click next, this is a weekly improvement rate. Before February, you can see a flat line because we did not have the capability of weekly run charts, but there was an improvement up to 38% from 30% in terms of the screening rate that we are taking out of the EMR. Next, please. This is sharing the stool test that is done correctly. And thankfully, this, if you look at the PDSA2, which is right after giving the patients the simple instructions, we have found an improvement up to 73% in the number of patients that are returning the kit correctly. So there's the labeling is correct, the stool is collected correctly, and it's able to be processed. Next, please. So surprisingly, the rate of a positive stool test is quite high. It's about 24%, 24.7, but one of the biggest wins for having a patient navigator, although it was only 4 hours per week, we were able to increase significantly the number of diagnostic stool tests, diagnostics colonoscopy after a positive stool test, getting up to an 85%. Another reason for this success is that we emphasized for the residents to discuss with the patient that if you are to do a stool test, if it's positive, have the expectation of a colonoscopy, which is similar to the idea of lead messages and discussing expectations with the patients. So the decision to do this colonoscopy was much easier later on. Next, please. Limitations. A big point that we learned during this project is that when we initially collaborated with one GI clinic, we had a long wait time for the colonoscopy. So we had to involve different clinics to improve the wait time. So it's not, there's no gap between the decision making with the provider and scheduling. We also, as I mentioned multiple times, the simplified instructions made a great improvement on the completion rate for the stool test. Not having a population health registry was definitely a barrier, but luckily we're able to work on some right now. Next, please. I think as a conclusion and something to get out of this project is understanding that the importance of having a QI team that is highly functioning and addressing social determinants of health in your center is important. So using tools that would address the barriers within your population is very important. And having the EMRs and EHRs being leveraged and optimized would make the process much easier. Next, please. Some recent PDSA cycles that we just started on, the videos that we did, we conducted a pilot study to get some feedback from the patients, whether it improved their knowledge and their interest in doing the tests. We sent mass mailing reminders in, again, 3 languages, Arabic, English, and Spanish. And finally, with working with IT to have a population health registry by ethnicity and by race as well. We're conducting a sustainability analysis. Our grant just finished in December, so hopefully this 6 months will help us to know how much the rate is staying and what next should we do. And we will involve the feedback and motivational interviewing as well. Okay, next. This is the sample of the cards that we just sent as mass mailing to just remind the patient's population that we have to call us to schedule and discuss colorectal screening. Next. Well, thanks for everyone, for the American Cancer Society, for the residents and the leadership in our department and in our clinic that helped us throughout the process. We had weekly meetings that, and definitely there is a lot to do after this as well. Next. This is some of the acknowledgement that we received to this project in the ACPM and the New York ACP conferences. Next. With that, I'm ending my presentation. I believe at the end of all of the presentations, we will have time for questions and any suggestions as well. And I will be handing it to the next presenter, I believe, Tiffany Taylor.
Hi, I'm Tiffany Taylor. I'm the director for the Department of Family Medicine here at Charleston Area Medical Center. You can go to the next one. This project is completely supported by the CDC for $500,000. It has been a great project, a 5-year project. You continue the next slide. Like I said, 5-year cooperative agreement. But it was really to engage hospital systems to be a community with our other resources. So hence the communities of practice model, be able to incorporate cancer prevention and screening interventions to the hospital system mission priority settings and quality standards, help facilitate community partnerships, like I said, to better address our cancer prevention screening. The team, which consisted of a lot more people, but these are the main people. Me as the director for family medicine, Emma Gilham, nurse navigator for colorectal cancer at the Cancer Center at CAMC, Kathleen Lanham, IT extraordinaire and was always so helpful for us. Deputy Commissioner Jacqueline Proctor has been very appreciative of her and her working with the senior services. Reverend Kay Albright, Health Equity Outreach Coordinator, and then our wonderful Shauna for helping us guide us through all this. Go ahead. So we really wanted to come up with a vision statement and an aim. So West Virginia would raise the awareness of colorectal cancer screening, decrease unnecessary deaths. We have a very high rate of unnecessary deaths in the state of West Virginia and very low screening rates. And we also wanted to really reach out to disabled seniors of LGBTQ+ communities and also remove some of that fear of financial burden. So we decided that by the end of last year that we would increase colorectal cancer screening by 4%. May not seem like a lot, but it is. And so we had 5 different practices all involved, and this was from 45 to 75. Next. So we have our evidence-based interventions. So we started with provider assessment, feedback, and then provider education, of course, some small media, and then reducing some of the structural barriers. Next. For this project and the 5 clinics involved, we provided the 2021 year-end baseline to the providers in the clinics. We're providing updated reports quarterly, and with the help of the West Virginia Health Network practice, we're identifying providers that have lower screening rates, identifying the cause so we can help work with them, also identify the higher screening rates and their best practices to increase. So we are measuring progress by increasing screening rates for all of our providers, of course. Next. Provider education, it would for the evidence-based intervention, multiple components. So Charleston Area Medical Center, CMC, has an EduTrack system, an educational system at home to our colorectal cancer screening training that we created through this project. We've also shared multiple links for continuing education, focusing on colorectal cancer screening with providers. We are measuring by the number of providers who take the trainings and by their assessed increased knowledge pre and post evaluation. Next, small medium. So that has been a focus area. We've sent out over 11,000 postcards to eligible unscreened patients, participated in Kanawha County Health Department podcasts. Those have reached about 35,000 of our areas covered residents. We're working on digital marketing currently with focus on geofencing to reach some of our targeted populations. We've also, of course, engaged the AMC's Facebook colorectal cancer awareness campaign video. It's been viewed over 600 times with over 1,200 unique individuals and 1,300 impressions. Next. So the structural barriers, transportation is the #1 cause of people in West Virginia not getting to screenings. We have identified some resources to assisting in this. The value of having the external partners, hence the community of practice. Deputy Commissioner Proctor from the West Virginia Bureau of Senior Services was able to help identify transportation options from the senior centers. So that's the start. We were able to help identify transportation options and get them through. Another barrier was with our LGBTQ+ population, who are more apt to get screenings if they trust the doctor who recommended the screening. Reverend Albright from Covenant House was instrumental in helping with the sensitivity training for providers and medical staff with Dr. Scout who did a webinar. He's the executive director of the National LGBT Cancer Network. Reverend Albright is also the lead for the Dr. Rainbow website, which I'll talk about a little bit later. We are measuring this by just the number of resources that we're identifying. Next, data. Next. So our goal, we were able to, in 4 of the 5 clinics, we were able to achieve our goal. We did struggle with one of our clinics, much more rural, but we've been able to continue to increase there. So we're continuing to work on that area. We think that's the next. Okay, no one's going to look at all that. Go to the next one. And next. Okay. All right. So health equity, that's been that's something that we really wanted to address. So I mentioned Dr. Rainbow. Dr. Rainbow is dedicated to the belief that every West Virginian deserves quality health care and a support network, no matter who they love or what gender they identify as. We're here as a resource to connect every person to an LGBTQ culturally competent healthcare provider, as well as just connect individuals to community services and groups that ensure that it's okay here. We're happy to have you. The website also allows for people to recommend a provider on this list, and then providers can self-identify. West Virginia, which surprised me, has more trans youth per capita than any other state. That was a very interesting fact that I learned. We have done a lot of outreach through our nurse practitioner in the Family Medicine Center. He volunteers at West Virginia Health Right, which provides services to uninsured population and is providing a lot of resources. We have a very large homeless population, and we have a lot of struggles here. And he's also performing some gender affirming hormone therapy. Sorry. And then his husband actually does work with the Ryan White program. And the Ryan White program is just right downstairs from us. So that works out really, really well. The Covenant House, so they focus on championing the rights of all West Virginians for food, housing, healthcare. They also offer direct services for people who need long-term social change through advocacy and education. So Covenant House has recently added an in-house clinic through West Virginia Health Right, which is awesome. They are working on reducing the structural barrier for the homeless to get colorectal cancer screenings. They've been able to get the homeless population tested using the FACHE test, but then what do you do when you follow up with a colonoscopy? Prep for colonoscopy is obviously challenging in the best of situations, but imagine being homeless. And so West Virginia Health Right is working to secure a room in the clinic for a patient to stay that needs to do a prep. As I spoke earlier, Covenant House provided a culture sensitivity training for healthcare professionals. There's also a website for online CMEs. And then we also have the geofencing, like I said, to a digital marketing to allow us to capture devices that enter a predefined boundary, such as a pride event, that type of thing, and allows us to send out some targeted messages. And we also provide services through, it's called CHASM, and it's Charleston Homeless and Street Medicine. One of our faculty members takes medical students out to the shelters and toiletries, socks, waters, references to places like Dr. Rainbow, West Virginia Health Right, those types of things, and basically connect them with other resources. Next, please. Since, of course, COVID, the senior centers have started to offer grab-and-go lunches. So this allowed us the opportunity to put the colorectal cancer screening infographic flyers actually in the lunch bag. We follow up with a survey to assess the impact of the messaging. And we've been able to identify assistance getting seniors from rural areas, which is a lot of West Virginia, to a screening facility. And that is about all, I believe. I thank you much. And Dr. Desai.
Thank you. So the title of my presentation is Utilizing Project ECHO to Stay Ahead of Colon Cancer. Next slide, please. Just a little bit about me. I've been interested in colon cancer screening since my time in residency. That's actually a picture of me in residency. I used to go around rural clinics throughout the state of Georgia to talk about provider reminders and to give provider education in an effort to increase colon cancer screening rates, because there's big disparities within what we call the have and the have-nots between the rural areas and the areas with more resources. So this is something that I've been interested in for a while. Now, after that, I took a position at the Medical College of Georgia. I'm currently serving as one of the medical directors for the Georgia Colorectal Cancer Control Program, which is a CDC-funded program, which I'll tell you guys a little bit about soon. And I'm also the clinical lead for the CRC screening project ECHO, which I'm going to tell you guys about as well. Next slide, please. That's just another picture of me at one of our clinics. All right, so hardest hit regions of Georgia. So this is, of course, a map of the state of Georgia. On the left is the incidence, and on the right is the mortality. And you can see in the southwest region of the state, the incidence of colorectal cancer is higher than the rest. This is, of course, a very rural area. This is where I practice. I do internal medicine, and I practice in this part of the state. And in the right, you can see the southeast corner of the state. This is also an area where the highest, there's higher mortality than the remainder of the state. This is also a more rural area of the state. So next slide, please. So we came together as a collaborative within many different organizations within the state of Georgia, so we can target specifically the highest impact regions of the state in terms of reducing the cancer incidence and mortality for colorectal cancer. And so this we came together with the organization Georgia Core, which is the nonprofit organization based in Atlanta. They were the ones that were going to host that CDC grant. They serve as the PI and collaborate with a lot of different organizations throughout the state of Georgia to work on reducing colon cancer mortality. And so we have an academic partner through Augusta University. We have federally qualified health centers. We have hospitals that are providing a linkage to colonoscopy. And the whole goal is, of course, to reduce cancer mortality in the state of Georgia. Next slide, please. And so our program, so fortunately we were funded, and our program is based on evidence-based interventions. So we do patient reminders, we do provider reminders, structural reduction of structural barriers, provider assessment and feedback is the evidence-based interventions that we're required to do. And we do patient navigation through Horizons, which is an organization based in Albany, Georgia. And then we do Project ECHO, which is a platform to disseminate knowledge. You can see on the right, this is our clinics. These are the green are the clinics in Southeast Georgia, the orange are the clinics in Southwest Georgia, and the blue are healthcare centers and endoscopy centers that have agreed to provide follow-up colonoscopies for us. Next slide, please. So this is just some milestones that we've had. So this is I know the text is kind of small, but the whole purpose of this slide is to show that we implemented clinics in a stepwise fashion. We have 15 clinics, and of course we're growing. But so far we have 15. We started in July 2020. Of course, there was COVID was big kind of throughout in 2020 and even 2021. So that created some barriers to implementing our program. But by March 2022, all of our 15 clinics, our original 15 clinics, had already been onboarded. And so we needed a way of communicating with all of our clinics. And so next slide, please. So in April 2022, we developed or we decided as a group that we were going to start using this platform called Project ECHO as a way of communicating with our clinics and and for the clinics to communicate with us. Next slide, please. So this is just some, I'm just going to very briefly go over this. This is something that we're proud of as an organization and as a program, that we were able to, in a very short amount of time, increase screening rates at all of our partner clinics, or the vast majority of our partner clinics, all 15 of them. And you can see some of the East Georgia clinics have gone up, 16%. Several of them have gone up 16%. And our Albany primary healthcare clinics, you can see if you look at under 2022, many of our clinics are close to or above 60%, which was the CDC benchmark for us to reach. And by the end of this program, it's a 5-year program, and this is just within a year, several clinics are already there. And so this is just the work that our group has been doing. Next slide, please. So this is more about Project Echo. So like I was telling you, one of the platforms that we utilize in a way of increasing screening rates was Project Echo. So Project Echo stands for Extension for Community Healthcare Outcomes. This is an educational concept or educational platform developed by a gastroenterologist, Dr. Aurora, who was based in New Mexico, to provide what he called telementoring for hepatitis C treatment. And so he developed this program as a way of reaching out to rural providers in New Mexico and teaching them how to cure or how to treat hepatitis C. He found that after going through this program, the providers in rural New Mexico had the same cure rate as providers at a large academic medical center. And so they published that in New England Journal of Medicine, and then the concept kicked off since then. So the idea is to get the right knowledge at the right place at the right time. And their motto is moving knowledge instead of people. This is on the bottom, a screen grab from one of our Project Echoes. And so we utilize the platform Zoom to do this, or to disseminate that knowledge and to bring our people together in order to do our Project Echoes. Next slide, please. So Project Echo utilizes this hub and spoke model. So the hub is usually an academic center or is where the experts are, and the spokes are the providers, or usually rural clinic providers or providers in other underserved areas that want to learn from the hub. But the key here is that it's not just it's not a unidirectional flow of information just from the hub to the spokes. It's bidirectional and multidirectional, and this is kind of the success of Project Echo is based around this model, where if you see the spokes, which are clinic providers, are also teaching the hub is teaching the clinic providers. And they're all, the spokes are also teaching each other, so that the providers are all learning from each other as well. And this multi-directional model of learning is what's been so successful is with the Project Echo. Next slide, please. So the Project Echo goals for the goals for our Project Echo for what we call the CRC Screening Project Echo was to initially just to create a platform for provider assessment and feedback. And so this is one of the evidence-based interventions that we have to complete. It's one of the grant requirements. And so as a way of doing that for all of our providers and all of the throughout the clinics throughout the state of Georgia, we figured if we have the same time, which is 4 to 5, in the same day, which is the first Wednesday of every month, it just makes it easier for providers to know when to come together to get assessment and feedback in order to help increase their screening rates. The second part of this is to create high quality, clinically relevant content to increase provider knowledge. This is where our content experts come in to teach our providers about different techniques and different content, different information surrounding increasing colon cancer screening. Now, the second part of this project was to scale our work. So then we decided that, it's great that we have this program as a benefit for our grantees, but we wanted to make sure that others can also benefit from the program. So we decided to open this up for anybody, anywhere in the country and really anywhere internationally that wants to participate, that wants to have their providers as part of the program in an effort to increase their colon cancer screening rates, are welcome to do so. And so the ultimate goal is to increase rates at health systems, not just in our state or in our health in our grant program clinics, but in the country and the globe. So next slide, please. So the way our sessions are broken down, we try to keep things interesting. It's a 1-hour session, and we try to have different components of the session to try to keep things a little bit more engaging for the providers. So we have, of course, we just start with a pre-session knowledge quiz. Then we have an expert presenter. We have a topic that's interesting to the providers. that we're able to talk about, the experts able to talk about it and teach about. Then we have a case presenter. The case presenter, this has been a really popular component of our session. This is one of the providers that's part of the program, wants to talk about something that they've done within their clinic. So something that they've done successfully, or sometimes barriers that they've had to get patients screened. So it's really a great section that the providers are able to hear from their peers on barriers or on successes that they've had. Then we end with a post-session knowledge quiz to see how much difference in knowledge there has been as a result of the program. And we also provide information to get CME. Next slide, please. This is just one of the flyers. So we try to disseminate the flyer and to publicize the session prior to. Next slide, please. So we've had a lot of high quality, just very expert presenters that's really added to the depth of our program. And so these are a lot of our presenters that have been associated with the NCCRT in various capacities. We've had, Dr. Iskowitz spoke about the pathogenesis and screening guidelines. We've had Dr. Coronado who spoke about patient reminders. Lisa Richardson, who's from the CDC, spoke about her colon cancer screening program. And then Dr. Bob Smith spoke about the value of starting at age 45. And these are just some examples of the type of content that we have as far as our expert information goes. Next slide, please. And this is just some more of our excellent providers that we've had. Content experts that we've had. Next slide, please. And so the second part of this is case presenters. So case presenters, I usually, to try to engage our providers a little bit more, I actually drive down to the clinics, I meet with the providers, I talk about issues that they've had. And based on those issues that we've discussed, we try to turn that into a presentation that's easy to digest for all of the providers that are participating. And so that's been another part of the success of this program. Next slide, please. So just some data that our analytics team or our evaluation team has put together. So we've had 10 sessions so far. We've had sessions from 17, or attendees from 17 different states. We've had 10 didactic presenters, 19 case presenters. We've had 30 different organizations represented, and the total number of attendees so far have been 592. Next slide, please. And so as I was saying, we do these pre and post session knowledge quizzes. And so this gives us some really good information on what the participants are learning and what they already know. And so one of the questions was, are participants able to correctly identify CRC screening age recommendation? And so pre-session was 89%, post-session was 92%. And so there was some increase in knowledge, but that was a question that or a piece of information that they already knew for the most part. Another question was participants able to correctly identify how long it takes for CRC to develop. This was one that only 57% knew pre-session, and post-session was 71%. And so this is some information that they're really getting and new knowledge that they're acquiring as a result of the program. Another question was participants able to correctly identify the EBI patient reminders as being something that helps increase colon cancer screening rates. Pre-session was 66%, post-session was 78%. So we did see some increase in knowledge on that one. Next slide, please. So other things that we really want to do is we want to reinforce the value of these interventions that we've been doing at clinics. And so, one of the questions we asked was CRC screening increases with implementation of EBIs. Pre-session was 21%, post-session was 78%. So a significant increase in number of providers that felt like the EBIs have been helpful. And these are providers that we've been implementing EBIs with, so it's important for them to believe in the project and then believe in the program in terms of the interventions that we're doing at their clinics. And the next question was CRC screening rates increase more if a clinic has a CRC champion. This is something that we've also tried to emphasize. Pre-session was 58% and post-session was 61%. This is CRC champions are something that we've been trying to implement in all of the clinics. And so this is something that we've been trying to emphasize during our program as well. Next slide, please. This is just a map of where all of our participants have been from. So like I said, we first started with just our state of Georgia, and then we've since expanded and we have clinics from all over the nation that have participated. Next slide, please. So our CRC, this is just data showing our attendance from session 1 all the way to session 10. So we've had around 50, sometimes more, sometimes less, but generally around 50 participants. We will open this up for more participants as well. We want more people to participate and more providers to be engaged from all over the country. So this is something that in the chat box, actually, I'll put in a way for others if you want to join. You guys are welcome to join. And of course, if anybody wants to be an expert presenter, that's something that we're also always recruiting for. So I'm going to do a little bit of a pitch here. So to make, if anybody's on the call, if they do want to participate as a participant or as a content expert, I'll put in my email and please do reach out to me. So that's my shameless plug. But that concludes my presentation, everybody. Thanks for listening. And I think we have some time for questions.
Well, thank you very much, Dr. Desai. This is fantastic. It's always engaging and exciting to see what communities are doing to address barriers to care and address our health equity barriers as well. So we have questions in the chat and we'll be taking questions all the way to the top of the hour. So I have a few that I've already started to scroll through, and we're going to start with you, Dr. Batarseh. So we have a question here from Lisa Whitemeyer. She said, can you elaborate on the actions the patient's navigator performed to improve screening rates? And did you uncover any insight unique to or specific to patients' ethnicities that could boost screening rates during your future outreach?
Yeah, sure thing. I think the patient navigator had different roles. One of the main ones that helped in improving the diagnostic colonoscopy scheduling is initially started by identifying the patients that had a positive stool test, and then looked quickly through the chart, checked if a colonoscopy discussion was documented. If the discussion is there, she would reach out to the patient and tell them, well, your provider has discussed with you a colonoscopy. How can I help you in scheduling it? Or what's your barrier to doing that? And kind of would identify either close the loop with the GI clinic or help the patient or reach back to us. So kind of someone is following through this process. If there's no clear information whether the discussion was there or if there's any documentation, for example, some patients has the fear they wanted to discuss it again with a provider, she would take it upon her, do a kind of a visit, schedule a visit for that patient with a provider. And that's kind of like from the backstage being streamlined, that there is a visit to discuss with the patient how to do a colonoscopy. In terms of differences within the ethnicities, we didn't have a kind of a thorough analysis on the differences between the ethnicities and like accepting to do the stool test. We're right now able to kind of pull the data from the population health registry that we're conducting, but we didn't, from like the feedback from the residents and the providers, we didn't have a specific kind of approach to different ethnicities. I think part of it is even the patients who are like most of the patients in our clinic do have kind of some education barrier or a language barrier or a financial. So it wasn't only related to the ethnicities.
Thank you for that. And we have another question from Madeline Tice. And that one is for Tiffany. Can you describe how the geofencing works? Do you need permission to send text messages, or is it an opt-in messaging program?
So we all know that Facebook and Twitter and Instagram are all listening to us all the time. And what geofencing actually does is we would predefine certain locations, say for a Pride event, and we can kind of put a fence around that too, as long as someone has their location services turned on in their phone. Then what it does is it will then produce some banners and advertisements on social media sites, those types of things, thus giving the person the opportunity to then click to express interest and then potentially connect with providers and other resources. So we don't need permission. It's not a texting service. And yes, your phone is listening to you.
Perfect. Thank you for that. And then I have a question from Mrs. Torres, and I'm going to link it with also a question from Allison Rosen. And that one is for Dr. Desai. They want you to share more about Project ECHO. Is there a set of educational curriculum that you're using, or are you setting that yourself with your program, your topics, your speaker, and the length in which the sessions will take? And then Allison asked, as a segue to that, was that 592 unique participants?
Sure. So our curriculum is kind of set based on our content experts, where like their expertise, that's the area of expertise. And so, but it's all around things like CRC pathogenesis. It's on different types of evidence-based interventions. And so it's all about things that directly relate to increasing colon cancer screening rates. And so it's about whether the interventions or the actual disease process itself, colon cancer, is generally what we're talking about. So it's pretty narrow, pretty narrow focus. And then our unique participants. So actually, that's not unique participants. Those are, so we generally kind of have a cohort, probably been around 50 now, that are generally with us, month after month. And so that's generally, so it's not unique. It's overall those total participants.
Thank you. And then we have a question for two of you. I think it actually applies, but you guys mentioned pre and post training assessment for the provider education. Did either of you follow up on the survey to see if the increase in knowledge persisted over time? For example, would it benefit CRC screening to do an annual provider education session?
Yeah, that'd be a good idea. We do ours every 3 months. We do a assessment because it's about the, like I was saying, roughly the same participants. So, but we haven't done it like yearly or anything to see if asking the same questions yearly. I think that's what they're referring to see if the change is sustainable or the knowledge is sustainable. So that's a good idea, though.
Yeah, I agree. That's a good idea. We did not have it also because the fact that we have residents that are graduating and kind of new residents coming up. So we already have to do the education part and kind of discuss it with them. So, but would be interesting for the kind of the residents that are staying in their second and third years before graduating.
Yeah, I would have to agree with that for sure. I know that I haven't done much follow-up as a result of those measures, but I think the past year and a half or so, was the first time that we did it, and we're able to get it up on the system. And same thing, residents graduating, so it would be interesting to follow through their years of residency.
Thanks for that. It's also my experience at provider education. You can offer it and then come and revisit. Information changes over time as well, and a refresher is always good. And then we have another question here for Dr. Desai. Can you explain what evidence-based interventions were used in the Project ECHO?
So Project ECHO, it was provider education and provider assessment and feedback were the two that were really, especially provider assessment and feedback was one of the 4. The CDC requires we do at least 2 out of the 4 evidence-based interventions that they have set for us. And so one of those are provider assessment and feedback, and that's kind of the platform that we use to do that.
Mm-hmm. And following from that is what percentage of healthcare providers were primary care physician versus internal medicine physician, family practitioners, gastroenterologist, and nurse practitioner?
Yeah, that's a good question. So generally, most of our participants are rural providers. So it's mostly going to be family medicine, internal medicine, and then a lot of nurse practitioners and PAs, because a lot of rural areas don't really have an MD. And so this is kind of like their main primary care is going to be your mid-level provider. And so we have participants from all over the country that are that are involved in one of the CRC screening programs. So like we have other grant recipients, for example, that are also participating.
Sounds great. Thank you, everyone. I'm not seeing any more questions in the Q&A. I'd like to invite everybody, if you have a questions, go ahead and put in the Q&A. I'm just going to segue in saying that there's definitely some commonality and continuous flow between the work that the three of you are doing, and having listened to your peers, and I know we talked back in November. What are some of the elements that each of your program, for you as a program implementer, you've gone back and looked at after hearing each other speak?
I can say we've talked about Project Echo from the original Project Echo way back, and we've talked about that over the years. And we actually have in West Virginia now, through Charleston Area Medical Center and our health network, telemedicine hubs where people in rural populations can actually just get to a place where they have internet access and can do telemedicine. I think I got an email today. I think another one just opened. So I know that's one of our things that we've talked about doing Echo before. And I remember back in November, I was impressed by Dr. Desai's presentation and kind of had that renewed interest. So I can say that.
I can say I personally, like, since I'm graduating, I'm only like looking to join FQHC clinics, which are going to be kind of helping underserved patients. So that was one of the things that I was asking them, like if they knew about Project Echo and how much they were able, like if there is the ability to be involved, since most of those areas kind of going to be a little bit rural as well. So they would benefit from such an approach. And I also kind of had in mind what Tiffany presented, given that she describe different issues that they had within their area because of being a little bit under-resourced, and how, because it's kind of different when residents are involved or residents are not involved, and like the areas.
Mm-hmm. I have to also segue and agree with everything you've all said. Project Echo is definitely a really good approach to addressing a lot of needs and reaching out to a lot of providers also in education. So I think that's a great tool. And I think a lot of us out there who are working on colorectal cancer issues can benefit from participating to other groups. I know Dr. Desai and I have talked about our participation in South Carolina, as we are so close to Georgia, and the work that you all do. So certainly putting my name out there if you need
We'd love to have you.
people to speak. Sounds great. Sounds great. And I see, as we're getting close to the top of the hour, I see that we have a few people who have requested to be in contact with our speaker panelist. That information will be shared back with our panelists, and they will be in contact with you. I know we haven't maybe necessarily answered every single question, but if more are showing up in our Q&A, know that we will be following with an email. I can't finish our wonderful webinar today without encouraging every one of you participating on this call to connect with the National Colorectal Cancer Roundtable on social media. The wealth of information that is available on the website is incredible. We also have several webinars that are posted on there. So be sure to visit our website, nccrt.org, to learn more about what is available and upcoming. We also want to take a minute to share a huge thank you to our speakers for taking their time and sharing their expertise today. We want to thank the American Cancer Society and the Centers for Disease Control for their support to the roundtable. Again, if you have any questions regarding today's webinar, please email us at nccrt@cancer.org. And I thank you all for joining us today, and I hope you have a wonderful afternoon. Thank you so very much. If you'll take a minute to complete our survey, that there's a link in our chat box, we would be most appreciative. And with that, I wish you all have a great afternoon.
Bye, everybody.
Thanks, everyone.